Giving a patient a blood transfusion is one of the most effective ways to save a life, but the margin for error is zero. A single procedural slip can turn a routine treatment into a fatal medical emergency. I'm Brooke Wallace, an ICU nurse and clinical educator. I'm here to bridge the gap between textbook theory and the high-pressure reality at the bedside. Before we break down today's protocol, make sure to hit subscribe and check out our platform for more clinical deep dives. Mastering the mechanics of this procedure is the only barrier between a standard shift and a catastrophic patient crisis. This is Nurse Sarah. She just received an order for 1 unit of packed red blood cells. Before that blood gets anywhere near the patient's IV, Sarah must complete a non-negotiable requirement, the 2RN verification. She finds a second licensed nurse, and they approach the bedside together. This chart shows the cross-match. They compare the patient's physical wristband directly to the blood bag label, verifying the full name, medical record number, date of birth, blood type, and expiration date. The stakes of this check are rooted in physiology. ABO incompatibility is the most frequent fatal error in transfusions. When types are mismatched, the recipient's immune system aggressively destroys the donor cells, causing them to burst inside the vascular system. Once the paperwork matches perfectly, the nurses perform a final visual inspection of the bag, looking for abnormal coloring, unexpected clots, or physical damage to the container. This deliberate, focused pause for verification is the nurse's primary defense against bedside misidentification. Moving to the mechanical setup, we use specialized Y-site tubing. This includes 1 spike for the blood product and a second spike for the compatible flush. A critical NCLEX rule: blood is only ever primed and run concurrently with 0.9% normal saline. Dextrose and lactated ringers are strictly incompatible. The danger is chemical. Blood products contain citrate to stay liquid in the bag. Lactated ringers contains calcium, which binds directly to that citrate. This neutralizes the anticoagulant and causes red blood cells to rapidly clump and clot the line. Once the saline is primed, Sarah initiates the infusion at a very slow rate, roughly 2 milliliters per minute. Then she pulls up a chair. For the next 15 minutes, she remains at the bedside. This is the physiological window where lethal immunological reactions most frequently ignite. During this 15-minute watch, Sarah actively monitors for 4 distinct physiological reactions based on symptom clusters. Acute hemolytic reactions trigger sudden fever, hypotension, and intense flank pain. Allergic responses to donor IgA cause hives and airway constriction. Febrile non-hemolytic reactions bring 1 degree Celsius temperature spikes and chills. TACO, circulatory overload, leads to dyspnea, crackles, and high blood pressure. 5 minutes into the transfusion, Sarah's patient begins shivering. They gasp for air and complain of intense, radiating pain in their lower back. By rapidly decoding these specific symptoms, Sarah gains the clarity needed to diagnose an acute hemolytic reaction in real time. Sarah's very first action is immediate. She reaches out and completely stops the transfusion pump. She must now avoid a common mistake. Instinct might tell a nurse to use the saline flush already attached to a Y tubing to keep the IV open, but she cannot do this. Flushing the existing line while the blood tubing is still attached acts like a plunger. It takes the trapped, highly reactive blood sitting in that tube and pushes it straight into the patient's bloodstream. The correct intervention is to disconnect the tainted blood tubing entirely from the patient's IV hub. To maintain access, she attaches a brand new bag of saline with completely fresh tubing directly to the IV hub. This keeps the vein patent and supports hemodynamics without administering more of the reactive blood. Establishing absolute control over these physical lines prevents further poisoning and stabilizes the patient for the provider's next orders. With the patient stable, Sarah notifies the provider and the blood bank. She places the tainted blood and tubing into a biohazard bag and sends them to the lab for a full investigation. Sarah began the shift with a sense of uncertainty. She ended it by stabilizing a crisis because she anticipated the danger and acted without hesitation. Remember the rules: the 2RN check, normal saline only, the 15-minute watch, and the stop, disconnect, new tubing protocol. If you want to master more clinical protocols, hit subscribe and join us on our platform. Clinical confidence is built on the exact mechanics of the rescue. Mastering these physical steps ensures that when a reaction ignites, your response is automatic.